right, Susan, welcome to the show. For anybody that doesn't know you and isn't aware of your work, could you tell us a bit about your background and what first got you interested in schema therapy?
Sure. Thanks, Neil, and thanks for inviting me. I'm a clinical psychologist and a schema therapy trainer and supervisor. And I originally trained in Australia, but have been practicing in the UK and Scotland on and off for 20 years. And I found that in a lot of the work that I was doing, I guess a lot of people improved with our first line treatments with CBT, for example, which a lot of people are familiar with, and other solution focused therapies. But then a lot of people get stuck, get to a certain point where they aren't able to make any further progress, or they feel like they might, I guess, understand intellectually that, I'm not worthless or I'm not unlovable, for example, but I still feel worthless. I still feel unlovable. I still feel like I won't get what I need in my life. And so I guess it's really what got me into schema therapy was really the search for something that was a bit deeper, something that would help people at an emotional level, not just at an intellectual level, to change deep patterns in their life and to start to get their needs met, really. And
Mm,
schema therapy really hit the spot there.
that's fantastic. And I think that's something we should definitely cover later on in the interview is bridging the gap between intellectually knowing something and then um, knowing it at an emotional level, because I think so many people struggle with that. I think that's so important. But next, Susan, I think it would just be good to ask you, what exactly is a schema? Like, how would you explain the concept of a schema to a 10-year-old, for example?
Yeah, okay. I mean, a schema is really, I guess, the way that the beliefs that we have, or the way that we think about ourselves, the way that we think about others, the way that we think about the world, is what we learn. And often, we hold these ideas at a very unconscious or automatic level. So for each of us, our schemas are almost like, for a 10-year-old, like the cellophane through which the lens through which we view the world, which explains, of course, why we all see the world quite differently. And there are many different factors which affect our beliefs, but I guess our childhood and adolescent experiences very much shape our perception of the world, of what we can expect from relationships, of what we can expect from ourselves. And they drive, I guess they're made up of thoughts, feelings, behaviors, or they drive behaviors, our felt sense, how we feel in our bodies, and memories. So they're kind of, I guess, themes in our lives that repeat themselves over and over and over again. And as I say, they're kind of developed through this interaction of nature and nurture. So
Mm.
partly our temperament and partly those experiences, and in particular, I guess, the experiences that we miss out on, or the gaps in our childhood, potentially that will lead to the development of a dysfunctional schema, whereas the good things, the positive things in our childhood, will lead to positive schemas, positive beliefs about ourselves.
100%. And maybe it'd be a good time now to talk about some of the origins of schema therapy. And I think the guy that made it was Jeffrey Young. Is that right?
Sure, yeah. Jeffrey Young developed schema therapy in the early 90s. He was a psychologist who trained with Aaron Beck, who's the founder of cognitive behavioural therapy. And he was working, I guess, with a lot of people with quite long-term or entrenched kind of chronic difficulties, borderline personality disorder, a lot of complex trauma, people with addictions, those, and relationship problems, and just found that I guess people were getting stuck in therapy, that they could only get so far, and was still, I guess, coming up with this, I still feel like, I still feel worthless, I still feel unlovable, I still feel that people don't care about me, for example. And so he was wanting to try something different and developed this approach really to, and integrating a lot of other approaches, the best, kind of pulling the best from a lot of other approaches. And he wrote the first client's guide, Reinventing Your Life, in 1994, and thereafter wrote the clinician's guide to schema therapy.
Fantastic. And so you mentioned there that schema therapy integrates a lot of different approaches. Maybe if you could tell us what some of these approaches are.
Sure. So it really draws on, it does draw on cognitive and behavioral therapy. It also draws on psychodynamic therapies, Gestalt therapy. It also draws quite heavily on attachment theory.
Mm,
And so what we know from the research on the way that um, that we develop, I guess, our relationship templates from the way that we experience relationships with our parents and other important people in our lives, and developmental theory. So a lot of the research on children's development and how, I guess, what we need at different stages to reach optimal development. So it really draws on, as I say, a kind of a real range of other approaches. And it's an evolving model. It's still growing. It's growing and developing all the time. And there are a lot of creative thinkers in schema therapy who are always expanding the model and integrating further.
that's fantastic. I think there are some disciplines within psychotherapy that can maybe become a bit entrenched in their own thinking or whatever. So that's so good that you guys are staying open and you're continuously tweaking and evolving and trying new things. That's great to hear. Um, what would you say, like, in what situations do you think schema therapy is most effective? Are there any particular, yeah, situations or conditions where it works best, would you say?
Sure. I mean, I think, to be honest with you, I think it it is suitable for working with any difficulties that haven't responded to first line treatments. So problems that are kind of long term, that have been around for a while, that feel a bit stuck, and kind of more entrenched or dug in kind of difficulties. And that includes a kind of more severe end of, I guess, the scale, with people with more complex trauma, personality disorders, those kinds of difficulties, but also, there's good research evidence for those kind of more severe difficulties with schema therapy, but also things like chronic depression, chronic anxiety disorders, eating disorders. There's emerging evidence that, I guess, shows that it's effective with these patient groups as well. But to be honest with you, it's also effective for anyone who's just wanting to learn more about themselves and work on their own, their own healing, their own development, really. So schema therapists, we believe in, that everyone has schemas, that it's not just those people out there with the problems, that as human beings, we all have schemas. None of us have had, I guess, a perfect life, a perfect childhood, and that we can all work on healing ourselves. And so schema therapists access their own schema therapy to work on their own material as well.
That's brilliant. Yeah, it seems that maybe I'm wrong, but it seems that a big goal that of schema therapy and a goal that schema therapists might have is that they seek to sort of understand like the underlying patterns that sort of repeat through a person's lifetime and their development and everything else. And I'm kind of curious, if someone sort of becomes slightly aware of like a repeating pattern, like something that keeps happening, maybe they get into a similar kind of relationship continuously. What advice would you give to someone who sort of might notice something like that in their own life?
Hmm. In schema therapy, we would generally take the approach of trying to figure out what's the unmet need. So what are the we have a range of needs that we would consider in childhood that everyone needs, that we all need. It's a bit like emotional vitamins, if you like. And if we don't get our emotional vitamins, if you don't get enough vegetables, or vitamin C, you might get scurvy, for example. It's the same thing happens for our emotional well-being. If we don't get the ingredients that we need as humans, and if we especially repeatedly miss out on certain ingredients, then it's potentially we'll get in patterns where we'll reenact that throughout our life. So, for example, if somebody grows up in an environment where, and of course, this is very common in the UK, there's this kind of, I guess, stiff upper lip culture, potentially. Where there's a bit of emotional inhibition, where, for example, if it's a family who doesn't really do emotions, doesn't talk about emotions, doesn't show affection overtly. The child maybe doesn't get cuddled or rocked enough, or doesn't have an opportunity to talk about their feelings. Then they grow up kind of feeling like, you know, maybe make sense of that in terms of I don't matter, or nobody cares about how I feel, or my needs aren't important, those kinds of beliefs. Um, and then they expect other people to emotionally be disinterested in them, to not meet their emotional needs. So that they might be drawn through familiarity, through schema chemistry, as we call it, into relationships with people who are also emotionally cut off, who are not capable of meeting their emotional needs. And that feels familiar and normal because that's what they grew up with, but it also perpetuates that pattern of not getting their needs met. Or alternatively, they might find a partner that can meet their needs, who is emotionally warm and connected, but they act in a way that stops them from getting their needs met in that relationship. So they maybe don't ask for their needs to be met. They don't articulate what they're feeling. And so their partner has no way of knowing what they need. So I guess, yeah, we repeat those patterns that we learn unconsciously, because of course, deep down, we do want those needs to be met, but we repeat those I guess, less functional patterns in our lives, uh, and perpetuate the problem, perpetuate the schema.
That makes a lot of sense. And it strikes me that it's so sad that our cultures can have that kind of influence on our well-being, you know, like just a bad cultural idea that you need to have the stiff upper lip or whatever, and that can just affect the well-being of so many people, you know. So
Absolutely.
I'm curious, what would you say are these kind of core emotional needs that everybody needs when they're growing up? What would you say the fundamentals are?
So yeah, we all need, I guess, a secure attachment to others. So we all need, I guess, a sense of safety, stability. We all need to be nurtured. We all need to, I guess, feel like we're seen, like our inner world is seen. So to have, I guess, a parent who is loving and affectionate towards us, accepting of us. So rather than, I guess, unconditional acceptance, rather than our acceptance being, our worth being hanging on our performance in certain areas. So, for example, somebody who is in bouncing around different foster homes, for example, wouldn't get their secure attachment needs met. They're just kind of being moved around too often. That's really bad for children to have that experience, for example. We
Mm.
all kind of know that. But sometimes it's much more subtle than that. It might be that that the parent has an alcohol problem, or that the parents have divorced, or and that hasn't been amicable, that has led to kind of this insecure attachment to others. Autonomy, competence, sense of identity. So we all need to, I guess, have experiences where we are allowed to go out into the world and develop our sense of um, competence, and to have lots of encouragement and praise, and a sense that we're good at things, to find our thing, and to be, I guess, for other people to see who we are and help us find our own identity. Freedom to express our needs and emotions. This is a really important basic need that we were just talking about. Spontaneity and play. So, when I guess things are too work focused, or too, academically focused, there isn't enough spontaneity and play, and that's a really important, such a core need for children in terms of developing a sense of self, a sense of who they are in the world. Also, of course, on the other end, needing realistic limits and self-control. Needing a parent who can set boundaries and stick to it. And that's easier said than done, of course, when we've got kids who, lose the plot when you tell them to come off their screens. And, it's really hard to set consistent limits. And I think if we as parents haven't had anyone who's been able to do that in a healthy way rather than in a punitive way, it's hard for us to I guess, get that right. Um, and there are other needs that have been suggested as well, such as a need for fairness, a need for a meaningful world, a need for connectedness to nature. So these are, I guess, needs that are kind of being incorporated into the model. But as I say, they're all like emotional vitamins, and we need to, I guess, we're looking in schema therapy at which of the needs were met in a or not met in a consistent way, because the ones that were not met in a consistent way tend to develop into schemas through interaction with temperament.
That's a great overview, Susan. Thank you so much for, well, it's amazing to be able to remember all those. Um, One of the things that sort of jumped out at me was just the example of play, and I think this might even go for adults as well. Like I remember during the first lockdown last year, I think I just sort of threw myself into work and just sort of put my head down that way, and then didn't really have any kind of play or anything for a long time, and then I was round at a friend's back in Ireland, and we started playing a game of ping pong, and it was just such a relief and a release. It was just like, why am I not doing something this like every day? Like it's free. It was such an eye-opening experience for me.
And
Um,
I think that's such an important point, Neil. And I think when it comes back to, back to culture, our culture doesn't necessarily place high value on these things. It's our culture, we have cultural schemas, and our culture places, I guess, higher emphasis on work, on productivity, on material success. But we know from the research, these things do not add up to well-being and happiness.
100%, 100%. So it seems that whenever these needs aren't met, particularly at a young age, that we develop maladaptive schemas to sort of to meet them, but we meet them in ways that actually aren't going to sort of fill the hole. Is that right? Could you maybe tell us a bit more about that?
Yeah, absolutely. So I guess those schemas, can develop, through that repeated pattern. So for example, it might be something like a parent who has postnatal depression or something like that. It might be something, that they just can't help, that it just happens and it's not nobody's fault. And the mother might be quite unresponsive and cold to the child because she's suffering herself. But then the child experiences this as, I don't exist, I don't matter, I don't exist in this world, nobody cares about me. Or they might make sense of it in terms of, it must be because I'm worthless, it must be because I'm unlovable that my mother can't show me love. So the schemas are sometimes the direct experience, sometimes how we make sense of the experience. Obviously it's not the case. In most cases the parent loves the child very much, but in this case, the parent's unable to show it. In the case of, for example, abuse, it's the same sort of thing. The parent might be, or the abuser, whoever that person is, might be telling the child, it's something wrong with you. You asked for this. You're the problem, and the child might internalize that message. Or it might just be that they make sense of it in that way. This person's abusing me. I must be bad. I feel disgusting and I feel bad. It must be because I am bad. So the schema kind of evolves in a sense, in an automatic way. And then we develop coping mechanisms to deal with those schemas. So we either kind of fight, flight, and freeze, if you like,
Mm.
to deal with that awful felt sense of I'm defective, or I'm bad, or I'm unlovable, or no one wants to hear about my feelings. We develop ways of coping and surviving, that, as a way of numbing the emotional pain that comes with unmet emotional needs.
It's really interesting. So, and then a schema therapist will maybe work with the client to bring more awareness to these maladaptive schemas and then find more adaptive ways or more, yeah, like better ways to sort of meet these needs in a healthy way. Is that right?
Exactly. So we would be looking at, instead of looking at, for example, why are you binge eating, or why are you binge drinking, or why are you self-harming, or, why are you working such long hours? Let's see if you can stop that. Instead of just looking at it on the surface, we would be looking at, okay, what need were you trying to get met by doing this? How was this behavior designed to help you originally? And then we would be looking at, how can we actually find a more healthy way of getting that need met, so that you don't need to keep doing it, keep coping with it in that way?
Mm.
How can we get that need met in a more fulfilling way, so that you don't need to binge, or to do whatever it is you're doing? So, because all of these behaviors, they sound dysfunctional, self-harm, all of these things, binging and so forth. When you understand the context in which they emerge, they make perfect sense. I'm yet to meet somebody where, when you really unpick what's going on, you can really see that makes sense when that emerged in your in your environment, in your childhood, and you weren't getting your needs met, but you found this way of getting your needs met, and that's really clever.
Fantastic. One of the things that I really love what you said in your webinar with the BPS, schema therapists come from the point of view, they're not looking at someone and asking what's wrong with you. They're asking what's happened to you, which is a much more compassionate way to approach a problem, I think.
Exactly. And I think that's a really important stance of the schema therapy model, really, is it's depathologizing that, we see that everyone has schemas, everyone has, I guess, developed ways of thinking about ourselves and others and the world. And we want to unpick that, understand that. And as you say, it's what's happened to you. How did this develop? Where did you learn this about yourself? Yeah, because no one's inherently defective, that's the reality, even though we might deeply feel that we are. That's just the way we've made sense of what's happened to us.
100%. So another key concept I'd kind of like to move into now, Susan, would be just this idea of modes. Could you tell us a bit more about modes in schema therapy and how they differ from schemas?
Sure. Schemas are really, clusters of schemas are what the modes are. So it's really, I guess, a way of, because we have, up to 18 schemas, maybe more, and so we still understand what's going on from the perspective of the schemas, but often in the here and now we'll work with modes. And modes are, I guess, different parts or different sides of ourselves. We all have these different parts, and they're like moment to moment emotional states and coping responses that we all experience. So often our schema modes are triggered by life situations that we're sensitive to, like our emotional buttons, if you like. And when our schemas are activated, our modes come to the surface. So we have these different parts. We have these child parts, these innate parts that hold all our feelings. We're all born vulnerable. So we have an inner vulnerable child that feels potentially sad, lonely, upset, distressed, anxious, all the emotions. When we're in touch with that part, that's our inner child or inner vulnerable child. We might have an angry child. If my husband eats all the chocolate in the chocolate cupboard, that might bring out my angry child part, for example. But I've still got access to my healthy adult part. So in my case, for example, and in most healthy integrated adults, we can access different modes at the same time. So I might be able to, my angry child might come up, but my healthy adult's already there, also soothing me and saying, it's okay, you'll cope, you'll get through it. It's okay, we'll find a way of coping with this. Whereas for some people, their modes are much more, I guess, cut off from each other, detached from each other, fragmented, if you like. And in those cases, then the person doesn't have much control over them. So, for example, in borderline personality disorder, the person might be flipping between one mode. They might feel detached, then they're angry, then they're really distressed, then they're kind of blaming the therapist, then they're numbing out. So they're moving between these different states, but they don't really feel like there's any control over that. There's no healthy adult part that's running the show. So it's a bit like we all have this internal orchestra, and a conductor is your healthy adult part that can kind of coordinate the other parts and make sure they're all working in harmony with each other. And for some people who haven't had enough of the right ingredients, they don't have a strong enough healthy adult part. And so there's just all these different parts that are trying to jump into the conductor's chair and then chucking each other out. And it's just chaos, Or you might have somebody who has a different picture, who's is more of a rigid picture, where there's just a coping part, maybe a numbing out part or a very controlling part, who is in the conductor's chair and basically stuck in that part. So, for example, someone with anorexia, for example, or someone with obsessive compulsive disorder might find that they have one part that's a very sticky part that runs their life, and it's very difficult to access their other parts of themselves, their vulnerable emotional part of themselves.
It's so interesting. So it seems that someone who's got sort of good psychological health, I don't know if that's even a proper term, but if someone who's, you know, in a good state of mind, they have more freedom to choose their response whenever one of these modes does sort of come online. Whereas someone who maybe is just doesn't have that, or maybe someone with BPD, they're just taken over by their mode, and then they're sort of just like, it's sort of like, it's almost like possession. You know, it's
Hmm.
just, it just takes over, and that.
Exactly, exactly. Yeah, yeah. And I think part of the work in schema therapy is about getting to know all of these different parts of self. That often what we learn in childhood is that these parts of you, they're not wanted. You know, nobody wants to hear about your feelings. Nobody wants to hear about that angry part of you. No one wants to see that impulsive part. So those parts kind of get locked in the cupboard or
Mhm.
locked in the dungeon. And those parts, you know, are trying to get some airtime. They're because they're part of ourselves. And so they will pop up in dysfunctional ways if we don't integrate them in healthy ways. So part of what we're trying to do is actually welcome all of the modes, bring in that vulnerable part. We're not wanting to eliminate the vulnerability. We want to embrace that, because the vulnerable part is the key to intimate relationships, closeness, being able to experience meaningfulness in life. And so we want to kind of turn things around from, um, you know, often clients will come to therapy saying, I want to get rid of that vulnerable part of myself. And we want to turn that around to, well, let's get to know that part of you, because that part of you is the key to your happiness, you know, embracing that part and taking care of that part of you, and learning to, I guess, nurture yourself in a compassionate way is the key to healing and happiness ultimately.
100%. And I think this is maybe one of the most, so we've covered a lot of different approaches to psychotherapy and things through our work at the Weekend University. And this is quite a recurring theme, that we all seem to think of ourselves as like one individual or whatever, but more and more it seems the case that we're a multiple, you know, we're multiple selves, and each, there's a bit of conflict between and everything else. And I'm just curious, has there been any dialogue between the schema therapy world and the world of internal family systems? Are you aware of this approach to?
Yeah, yeah, absolutely. And there is actually a huge overlap between these two approaches. There isn't much discussion between these two worlds, but there is a huge amount of
Mm,
overlap. And I think a lot of schema therapists have also done the training, you know, done some training or have some interest in, and probably vice versa as well. So yeah, absolutely. They're both come from that stance of we have to work with these different parts, we have to integrate these different parts and take care of and heal, I guess, the parts that are, that have been exiled or been, yeah, kind of, shut away and rejected.
100%. So I, I think a good thing maybe to talk about now. So there's two different phases of schema therapy. Is that right?
Absolutely, yeah, yeah. So there's the assessment phase. So this I guess the starting point in schema therapy, it's not a manualized treatment, it's not a cookbook therapy. So we don't just kind of come in, here's your treatment, off you go. Session one, we're doing this, session two, we're doing what we do in schema therapy is we really want to figure out, who are you? What's happened to you for this problem to have developed? We really want to understand and get it before we make any start to treatment. So we take out, we do take our time, and it's between 5 and 8 sessions. We're trying to figure out and put the jigsaw together and figure out, what does this person really need to heal. Um, During that time, we're also doing a lot of kind of helping the person to understand these different parts of themselves, to get to know these different parts. So there's already a lot of work happening. And then in the treatment phase, which varies in length according to, which treatment you attend, because it might be group therapy or individual therapy or a combination. Then we'll cover a lot of different work in over that period of time. Some of it is cognitive and behavioural. The majority of it is really experiential, is learning how to be in a relationship in a healthy way with your therapist, so that you have a new template for healthy relationships out in the world and getting your needs met in healthy ways. Um, and also experiential. So there's a lot of emotion focused work, a lot of experiential work, which is really back to what we were talking about before, uh, helping the person to feel differently about themselves, to change the meaning of their early experience so that they think differently, think, I guess, in more healthy ways about themselves, and learn to get their needs met in healthy ways.
100%. Obviously, we don't have time to go through like all of the different ways that schema therapists help bring about change in the second phase. But two of the things that I sort of jumped out at me that was really interesting were the two chair work. Could you maybe tell us about that? And
Yeah,
then,
yeah,
yeah,
absolutely. Yeah, chair work is a big part of schema therapy, and we use it for a range of different purposes. But it's really about, I guess, this idea of, these different parts of selves of ourself. So sometimes, as I say, we'll be stuck in one rigid mode, or there might be several modes that the person is flipping between different parts of self. So we might give each of those modes a chair and give them a different say, and we get to know these parts and set up conversations between these parts. Now, it might sound a bit crazy, and sometimes people do look at me like, "Are you seriously kidding?" But actually, it's very powerful because it does create, I guess, this inner, it gets this inner orchestra to start working together rather than all at cross purposes from each other. Um, so, for example, if I think of a client, we call her Mary, who might come to therapy feeling quite depressed, quite lonely. And she might come to sessions, and when I ask her how she feels, she might tell me, I'm fine. I'm fine. I'm doing okay. I've got these problems. Where I do feel there's lots of problems in my life, but whenever I ask her, how are you this week, I'm fine. So we don't get in touch with the feelings, and she never shows her feelings, and even though I know she's feeling sad and lonely, I know she must be because of the problems she's telling me about. She tells me she's depressed. It's not detectable from the way she speaks. She maybe speaks in a very numb or detached way, and very chatty, but not really showing any emotions. And if Mary might also be having problems with her husband because her husband kind of isn't meeting her needs, and she maybe feels frustrated about that, but also her husband potentially can't see what it is that she needs because she's got this kind of detached state. And so I might say to Mary, look, it feels like, I might kind of point out very gently that I get this sense that there is this part that doesn't want you to talk too much to me about your feelings. That's kind of almost like trying to protect you. And it feels like maybe a wee bit like a security guard sitting between us, or a translator. And that, that I'm saying something to the security guard, and he's kind of turning around and telling you, and I'm not getting any direct contact with you, and it feels like you're a long way away. And I wonder if we can bring in a chair for that security guard part, so that we can ask it why it needs to protect you. We might kind of ask, I might ask the chair, the empty chair, some questions, and then she would pop over to that chair and answer, from the security guard. I might say things like, when did you come into Mary's life? What was your job? How did you help her when she was a child? What are you afraid will happen if you let Mary talk about her feelings? Those kinds of things. And then it helps with people find that it helps because it helps them to start to recognize, hang on, that security guard isn't the only part of me. There's also this other part of me, this vulnerable part. And we put a chair here for the vulnerable part. And this is the part that has feelings. So we separate out this part that has feelings, that is here in therapy because she wants to heal, because she wants to connect and get her needs met, because she's lonely and she wants help. And there's this other part that's afraid because what this part has learned early in your life is, actually you'll be left all alone with your feelings. They'll spiral out of control. It'll be a Pandora's box. You'll just be left with all these scary feelings, and no one to help you. And so I might then negotiate with that part, that detached security guard, and about how, I guess, trying to help that part feel secure enough and that it can trust me enough to start to help Mary with that vulnerable part of Mary with those difficulties.
Wow, that's fascinating, and it sounds like it'd be a lot of fun to do. I don't know if fun
It
is the
is.
right word, but it would
It
be
is. It is. It's,
interesting.
I think that's one of the things I love about it. It's really creative. You can work with whatever your client needs, really, and you don't have to stick to the rules. There's no rules or manual. We have, there's a lot of training, and there's a lot to it, but you can, once you know the model, you can be really creative, and it can be a lot of fun. Yeah.
Awesome, and it sort of ties uh, back into what we were talking about earlier about how these different modes, and people that are psychologically healthy, they're able to sort of choose a response to different modes. And if a schema therapist is helping someone that maybe has more difficulty with that, through something like chair work, it maybe helps them differentiate between these modes more, bring more awareness to them, and maybe a bit more acceptance as well. Is that fair to say?
Yeah, absolutely. So I think more acceptance of the modes which have previously been rejected and had no airtime at all, where they're kind of brought more into the fold and accepted more, and also even working with, I guess, the really critical mode, the mode that kind of represents all the external messages which have been negative or critical or in the person's life, to actually put that on a chair and set limits on it and challenge it. So they get that experience of someone sticking up for them, being protected in a healthy way. So we do that, I guess, through chair work and through imagery rescripting, which is our other main technique that we would use for experiential work, and some psychodrama techniques as well. Yeah.
That's brilliant. Now, for anybody that's listening to this at home, and maybe they've got an overly um, an overly active inner critic that's always just always beating them up inside their own head. Have you got any sort of exercises they might be able to do, like any journaling or anything like that there that they could do, or anything come to mind?
Yeah, I mean, I think that it can be helpful to first of all recognize and where does this come from? What are the, I guess, the different places in my life where this has come from? Sometimes it's direct messages from other people. Sometimes it's an inner critic that's been passed down through the generations, and no one kind of even recognizes it as that. Sometimes it's culture, sometimes it's teachers and peers, and it can come from these inner critics can come from lots of different places, or a mixture of those different places. But I think the thing to remember is most of our modes are welcome, because they're part of us. We've either created them or we've been born with them. The inner critic is usually, I guess, an external. It comes from outside, and therefore it's not supposed to be integrated. Now, it's different if we have a self-harm or a critical part that's a coping part, then we would integrate it. But if it's a true inner critic, and it's come from these, I guess, outside voices and messages, we want to set limits on it. So even just kind of drawing that inner critic, what would it look like if it was a person or a shape, or let's just kind of make it a thing. What does it sound like? What would its voice be like? What would its eyes be like? What would its message be? And just draw it so that it's not, because it gets its power quite often by being this kind of nebulous thing that just kind of seeps in and does its work. And so we really want to set limits on it. So especially if it's a lot of these modes are like bullies, they're like inner bullies. We want to set limits on the bully. We don't want to get into a big conversation with the bully and justify what we're doing. We want to just say, back off, mister. I don't want to deal with you. I don't want to deal with this. I'm not. And sometimes in therapy, the therapist will help with that and do a lot of that work with our clients. But I think for those of us who already have a strong, healthy adult part, we can actually set limits on it. So it's partly about recognizing it. If I'm feeling guilty and I don't know why, or if I'm feeling like I'm a bad person, or I hear that inner critic message, I can kind of just say that, back off, leave me alone. Don't you speak to me like that. I won't have that.
Mm.
So it's just kind of really setting a healthy limit, like you would with a bully.
That's so interesting. I love that idea that, maybe the inner critic has its power because it is so nebulous and vague and ambiguous. So if you can sort of make it more concrete by even drawing it, and whenever you're talking about that, I'm just picturing this like horrible like thing. It's pretty horrible. But yeah, I wanted to ask Susan just before we finish up about trauma. Is this approach used in treating trauma at all? Schema
Absolutely.
therapy.
Yeah, yeah. It's an ideal approach for working with trauma,
Okay.
and in particular, imagery rescripting is a method that we would use for working with trauma, childhood trauma memories. There's been quite a bit of research on that, and in fact, a recent study comparing imagery rescripting with EMDR. For complex trauma memories, and found they
Mm,
were equivalent, both very effective.
wow.
So, um, so it's a very effective way of working with, I guess, those early traumatic memories and abuse memories that some people have, where they're left feeling I'm bad, or there's something wrong with me, or so the meaning of that event can be shifted through imagery rescripting. So that when we do imagery rescripting, we're not changing reality. We can't change reality, but through imagery rescripting, the same parts of the brain light up as in the actual event. So we actually kind of almost switch on those same emotions, and that means that we have kind of more plasticity, if you like, to change the meaning of the experience. And so it's a very powerful way of uh, learning, of doing the healing work, where the person experiences getting their needs met, being protected, and having a different ending, a different experience of childhood, and what it would look like without those, I guess, those abuse experiences. Having that experience of being protected, and someone sticking up for them, and being cared for.
Brilliant, brilliant. Well, if anyone's listening to this and maybe they're a mental health professional and this is the first time they're coming across schema therapy, what would you advise as kind of next steps to maybe learning more about the approach?
Mm. There is um, a range of courses across the UK and across the world on schema therapy. We run our own at Schema Therapy Scotland, so that's schematherapyscotland.com. And as I say, if you go to the ISST schema therapy website, there are others listed for the UK. There are also online, pre-recorded online workshops at schematherapytrainingonline.com, and they're kind of quite a nice taster to the model, and quite a good way to start. So a range of options for people. A lot of books have been written on the topic. A lot of videos on YouTube and so forth. So there's a lot of opportunities and options available.
And for anyone that's interested in taking your training, Susan, what's the website they can find that out?
It's www.schematherapyscotland.com.
But you train people, I take it, from all over the place, yeah, not just in
Yes,
Scotland. Is that right?
it's
Yeah.
all, yeah, absolutely. So it's all online at the moment, and anyone can attend from anywhere. And in fact, we have people attending from Europe, different places in Europe, Australia. Sometimes the time zone's a little bit wacky for people, but we often have kind of quite dynamic workshops with people from different places. I also run workshops on specifically on schema therapy for eating disorders, and we have schema therapy on a range of other topics as well on offer. So, and of course, there's a large randomized controlled trial that's just come out, also showing that it's very effective for forensic populations. So there's a lot of new evidence coming out for different populations, and I think that whatever specialist population you work with, it can be profoundly powerful approach to use.
Brilliant, brilliant. We'll link to that in the show notes for the show, Susan. And just before you go as well, any books you'd recommend for someone to sort of follow up on this, just for the average person that wants to learn more?
At the moment, the Reinventing Your Life, as I say, is kind of, I guess, the first one. It's been around for a while, 1994. It still does, I guess, give a good overview of the original schema therapy model. There's another book called Breaking Negative Thinking Patterns, Gita Jacob, which is looking at the mode model. And there are several books that are in the process of being written, for the general public to read. So watch this space, really. We'll have them on up on our website as well to advertise them and let people know about them. But yeah, they're the main two that are out there at the moment for I guess, people who might be interested in having their own schema therapy.
Great. And there's a great talk as well that you've given online for the BPS. It's a webinar. It lasts maybe about just over an hour. For anybody that wants to sort of go in a bit more depth, I would definitely recommend checking that out. And yeah, so just before you go, I just want to say, at the Weekend University, we're all about sort of making these approaches to psychotherapy and psychology more accessible. And I just want to commend you because you're certainly doing that. And I've loved every second of talking to you today. It's been really fun. So just thank you very much. I really appreciate it. And I wish you the best going forward.
Thank you so much, Neil, and thank you very much for inviting me. It's been my pleasure.